All right, let's jump straight in. Most vertigo you'll see in the emergency department is entirely benign. But a small, highly lethal minority is actually posterior circulation stroke, dangerously disguised as a simple viral illness. Welcome to part 1 of our 3-part explainer series. Today, we're unpacking a highly time-critical clinical guide covering 4 vascular diagnoses you absolutely cannot afford to miss. We're looking at conditions that hide right in plain sight but carry completely devastating consequences if left untreated.
There is a chilling reality we need to confront right up front. A dizzy patient who walks into your ED on day 1 looking completely stable can literally be dead or decerebrate by day 3. That's the exact trap of a missed cerebellar infarct with malignant oedema. Our primary goal today is to totally shatter the illusion of safety around acute vertigo and figure out the exact clinical patterns we need to spot to escalate care before the survival window closes. And we're drawing directly from the latest clinical guidelines compiled by Australian Dizziness Clinics here. We're going to frame every single presentation today through the lens of time-critical intervention windows. The foundational principle we're working with is that none of these life-threatening conditions can be reliably excluded by a bedside exam alone. When the clinical pattern raises your suspicion, your vigilance is the absolute best tool you have.
Here's our roadmap. We'll start with how these conditions disguise themselves, then walk through cerebellar hemorrhage, malignant infarct, vertebral dissection, and finally, basilar occlusion, before locking in our time-critical takeaways.
Okay, so let's talk about this lethal disguise.
These vascular emergencies are absolute master mimics. They often masquerade perfectly as vestibular neuritis, presenting with pure vertigo, nausea, and unsteadiness long before any focal signs declare themselves. To spot the killer in the room, we have to look past the dizziness itself. Benign vertigo is typically positional or isolated, right? But look at the red flags here. Severe headache, new focal signs, an acute drop in the Glasgow Coma Scale, or astasia, which is the outright inability to stand up unaided. If you see any of these, we are no longer dealing with a simple inner ear issue. We are looking at a potential vascular catastrophe.
If you picture the highly complex vertebro-basilar system, including the PICA, AICA, and SCA branches, you can see exactly where these catastrophes happen. An occlusion, dissection, or hemorrhage at literally any level of this posterior circulation produces the exact stroke syndromes we're covering today. Getting a spatial feel for this anatomy really helps explain why these blockages present the way they do. Let's break down our first specific killer, cerebellar hemorrhage.
This is a neurosurgical emergency, pure and simple. It typically hits patients with a history of hypertension, folks on anticoagulation, or people with underlying vascular malformations. Clinically, you are watching for classic triad, the acute onset of a severe occipital headache, intense vertigo with vomiting, and astasia. And I want to really stress astasia here. Being unable to stand or walk unaided is a massive, blaring red flag for profound cerebellar pathology. A patient with a viral inner ear infection might feel completely awful, but they can usually still stand. A hemorrhage patient often just can't. The mortality rate spikes incredibly fast the second brainstem compression or obstructive hydrocephalus kicks in.
So when you see that triad, your immediate next step is non-negotiable. You need a non-contrast CT right away. It's highly sensitive for acute hemorrhage, and we need to know instantly if that bleed is expanding or compressing critical structures.
Once you've got that scan, you're hunting for specific surgical triggers. If you see a hematoma volume greater than 3 centimeters in diameter or any compression of the fourth ventricle, that mandates immediate escalation. Early emergency suboccipital craniectomy by the neurosurgery team can rapidly decompress the posterior fossa, literally saving the patient's life before irreversible brainstem damage happens.
Moving on to our second diagnosis, malignant cerebellar infarct.
This one is a massive trap. Large cerebellar infarcts don't always look catastrophic when the patient first rolls through the doors. Look at the timeline. At hour 0, the patient might present with what looks like pure vertigo. They might actually appear totally fine. But between 24 and 72 hours, devastating, space-occupying vasogenic swelling peaks. And by that 72-hour mark, if they aren't being aggressively monitored, the patient rapidly decompensates from brainstem compression. Because of that delayed swelling, the guidelines outline a crucial protocol. Any patient diagnosed with a large cerebellar infarct absolutely cannot be sent home. Even if they are sitting up and looking completely stable, they require a mandatory ICU admission with hourly neurological observations. MRI-DWI is the gold standard to catch this early. And just like with a bleed, if they start deteriorating, posterior-fossa decompression is the surgical intervention that saves them. All right, let's switch gears to vertebral artery dissection. We are looking for a totally different pattern here.
We're stepping away from the typical older hypertensive stroke demographic. With this, the structural integrity of the artery is the core issue. We're talking about younger patients who have had recent trauma, whiplash, or honestly even just routine neck manipulation. Crucially, they'll present with ipsilateral neck or severe occipital pain. And here is the real kicker. This severe unilateral pain frequently happens before the vertigo and the actual stroke features hit, sometimes hours or even days beforehand. If that young patient trauma profile sets off your clinical radar, the pathway demands an MRI or CTA of the neck as your absolute go-to investigation. We aren't just looking at the brain anymore. We have to look down into the neck vessels to spot the intimal flap, a mural hematoma, or that classic string sign lumen. Once that dissection is confirmed on imaging, immediate management kicks in. Depending on your local stroke protocols, this means antiplatelet therapy or full anticoagulation for about 3 to 6 months. This is critical because it stabilizes the injured vessel and prevents the lethal clot propagation that causes a massive posterior circulation stroke down the line.
This brings us to basilar artery occlusion.
This is easily one of the most devastating stroke syndromes we face. If it's missed and left untreated in the ED, it carries an appalling mortality rate approaching 80%. It is an absolute high-stakes emergency. Presentation can range from pure vertigo to sudden, catastrophic decompensation. The glaring red flags are vertigo packed together with multifocal brainstem signs. We're talking altered consciousness, cranial nerve palsies, bilateral motor or sensory deficits, dysarthria, and vertical gaze palsy. In its absolute worst form, an untreated basilar occlusion results in locked-in syndrome. The patient is fully conscious but completely paralyzed.
But there is a crucial window of hope here. Early activation of the stroke team for a STAT CTA is paramount because endovascular thrombectomy is a highly viable, life-saving option. In fact, in certain high-stakes cases based on imaging mismatch, that window for thrombectomy can actually be extended up to 24 hours. But we have to recognize those signs and get the CTA done first.
All right, let's synthesize all of this. Knowing the anatomy is great, but building a rapid-fire clinical reflex is what actually saves lives on the floor. So here is your survival playbook. For hemorrhage, vertigo, severe headache, and ataxia mean you need a non-contrast CT and neurosurgery. For an infarct, it's at delayed edema risk, which demands an MRI-DWI and strict ICU admission. For a vertebral dissection, neck pain plus vertigo means a CTA and anticoagulation. And for a basilar occlusion, vertigo with multifocal signs means a STAT CTA and an immediate stroke team alert. Rigorous ED vigilance, trusting your clinical red flags over simple bedside testing is everything here. So if you only remember 3 things from this explainer, make it these. Number 1, vascular killers mimic benign vertigo right up until they don't. You have to actively hunt for those red flags. Number 2, in cases of hemorrhage or a massive infarct, early cerebellar decompression absolutely saves lives. And number 3, thrombectomy and dissection anticoagulation are exquisitely time critical. If you miss the window, the patient is lost.
And that wraps up part 1. In our next explainer, metabolic and toxic traps, we're going to examine diagnoses like Wernicke's encephalopathy and carbon monoxide poisoning, situations where the classic triad is almost always missing, and empirical treatment is what actually saves the day. Thank you so much for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating. Until next time, ask yourself, when the next benign vertigo patient walks through your ED doors, will you be looking at the symptoms, or will you be looking for the disguise?